Hello everyone and welcome to our first med student mini lecture for the IR section. I'm John Guynan, one of the IR attendings here at Bergen Mercy, and we're going to talk about 6 topics that come up pretty frequently in the world of IR, so we'll get to it. So the first topic we're going to cover today is embolization, or stopping of blood flow to a certain targeted area. This is something that comes up almost on a daily basis, definitely a couple times a week, and lots of reasons that interventional radiology would be doing embolization. I would say most frequently it's probably something to do with gastrointestinal hemorrhage, but bleeding from really any source, so bleeding from an airway, from an upper GI tract, lower GI tract, uterine fibroids, bleeding to do with tumors, and then sometimes we do embolization that's not really connected to active bleeding at all. We'll embolize tumors to treat them, or even potentially embolize tumors to decrease the risk of hemorrhage for a surgical procedure. So lots of reasons to do an embolization, and then lots of different tools that we can use for embolization, which we're going to touch on here today. So kind of the steps in evaluating and then performing image-guided embolization. So number one, we are radiologists, so we want to evaluate diagnostic images. It's actually pretty rare that we would do an embolization without pre-procedural imaging. It does happen occasionally, but typically in the setting of like a trauma, if someone is too unstable to undergo CT imaging, that means they usually go straight to the OR for a diagnostic laparotomy to figure out what's going on. I would say maybe the one caveat is sometimes if we're highly concerned about pelvic fractures, they might come to us without imaging, but again, that's very rare. So typically people come with pre-procedure imaging and kind of what's the order of things that we would like, or what's the order of our preference. Number one, the best way to look for bleeding would be a CT angiogram. So CTAs, especially for bleeding protocols, the images are obtained while there's contrast in the arteries, and then usually people get a venous phase and then a delayed phase. So those multi-phase studies help us to truly see where active hemorrhage is, and then we don't get fooled by something bright that's not contrast. If we can't get a CTA, just a normal contrast enhanced CT would be our second best. Not quite as good as a multi-phase CT examination, but still pretty darn good. If we don't have that, non-contrast CT is very limited. I'd say we can kind of evaluate the size of a hematoma if someone has it, but we can't really say if they're actively bleeding unless we can compare it to a prior and show that it's increased in size. Nuke med scans are very sensitive for bleeding, but they take a long time to obtain, and sometimes they're actually too sensitive where we can find bleeding on the nuke med scan and then look in that same spot angiographically and not be able to see it. And then not exactly imaging, but quite frequently people will come from the GI lab with endoscopy, and we'll either read the GI reports or talk to them directly, and they'll say something like, well, we saw a bleeding ulcer in the duodenum. It was too big or brisk for us to completely treat it, and we'd like you to do an embolization. So there's no imaging that we can review on that, but just having their verbal or written report, and usually clips, we can figure out where we need to go. So then after we've done all that, obviously patients get appropriate IV access and NPO status and all that other things, all the other prerequisites that you need for any other sedation type procedure. Then we'd bring them to the angiography suite, And then based on all the information that we have, decide on an embolization material, and then always need a angiogram after our embolization to make sure that everything is as we expect. So embolization materials, we're not going to go dive really deep into this, but there's lots of different options. Today we're basically going to be talking about embospheres, which fall into the particles. These are small, basically polymers, beads. They come in various range of sizes. The smallest that we would use would be 100 to 300 micrometers, and typically I'd say we use 300 to 500 micrometers. So these are about, 50 times bigger than a capillary bed, so getting close but not going all the way through. And then, coils are titanium filaments that will cause hemostasis within the blood, the vessel. And then an ampullator plug is a larger nitinol device that goes within vessels, and it's like being able to use multiple plugs at once, a little bit quicker for procedurally. All right, so we're getting into our first case here. This is a left gastric artery angiogram, and it does show some active hemorrhage. Hopefully you saw that. So it's a little bit tougher when we're just looking at one image instead of the kind of the whole series of images during the injection, but we can see that this is definitely not within a vessel. As we can see, all the small arteries here are pretty small, and this is just kind of free form outside of it. So this is a good look for an arterial blush and concerning for active hemorrhage. So what we've done is we've treated it with a coil within this vessel. Now typically for something like this we would want to use a sandwich method, which means we'd like to get coils out distal to the bleed and then proximal to the bleed, cover both sides of it, but this vessel was too small, so we just treated proximally, and it looks pretty good. And of course after we treat, we always do another angiogram to make sure everything was treated sufficiently. In this case, that first vessel was a small little branch vessel in the left gastric artery, and we found an even bigger bleed within one of the bigger vessels, branches of the left gastric artery. So in this case, we were able to do the sandwich method, and what we got some coils distal to and proximal to the site of bleeding. This is important because if it's not an end artery, meaning if the artery doesn't just supply a small area of parenchyma, that means it's going to have the possibility of retrograde flow into that vessel, and then it can back bleed, which we don't want to deal with. So if the bleed is here, we want to make sure we have coils on both sides, so we stop the flow from both ways, and then we stop the bleeding, which makes me happy. So this is our final image here, follow-up. This would be a celiac artery angiogram and no more bleeding to the stomach, which is good. This is another case. So we have our liver here and a very unhappy spleen on this side. So here is the area which is most abnormal, and we have some free fluid around the liver too, but we can ignore that for this moment. So our spleen is not really enhancing correctly. It should kind of look like the liver, and it's not. So there's some fluid, probably hemorrhage here, and then we have this lone bright spot, which is concerning for possibly active hemorrhage. So we took him to angiography, and we did a proximal, or this would be a splenic artery angiogram, and it is markedly abnormal. So our normal splenic tissue should enhance, kind of like this part of the spleen, but this part of the spleen is not really enhancing. And then beyond that, we have lots of truncated arterial vessels. So this is all consistent with traumatic arterial injury. Now, can we go and put coils into each one of these positions? Yeah, probably, but it would be time consuming, and this patient needs to be stabilized quickly. So another option we have is we can just use a vascular plug proximally within the splenic artery, decrease the inflow and the pressure so that the bleeding can stop. And then, you know, as long as you do it proximally, you don't cut off all the other small collateral flow to the spleen. So hopefully what little spleen is still being perfused can continue to be perfused, and maybe even some of these can recover. So that's exactly what we did. We put a plug here proximally, but we still see the short gastric vessels enhancing and some blood flow going over to the spleen. It's not an appreciable amount. It's not enough that they're going to bleed out from this, but hopefully we can preserve some perfusion to the spleen. And this picture is just what the plug would look like outside of the body. So we have a 3-month follow-up for this case, and you know, kind of what I was describing is exactly what happened. We have our plug here in the proximal splenic artery, and we still have some enhancement within the spleen. Yes, there's definitely some devascularized portion of the spleen and some evolving hematoma, but hopefully this is enough to give them the support they need, or the splenic function that they need. Oh yeah. So last case here, this is one that didn't have any pre-procedural imaging. This was the pulmonologist coming to us and say they bronched the patient and they had some active hemorrhage within the right bronchus. So we brought them for bronchial artery angiogram, and this is the right bronchial artery. And you know, it's very rare that we'll actually see active hemorrhage in a bronchial artery, but what you'll typically see is enlargement and tortuosity within abnormal vessels. So this is a little bit enlarged and it is a little bit tortuous, and actually we can see some like parenchymal enhancement, which is another odd finding. So all three of the angiographic findings and then also the clinical finding from the pulmonologist tell us that this is probably the source of the hemorrhage, so we want to treat it. In this case, this is one of the areas where we do not want to use coils. So people who have hemoptysis will often recur hemoptysis, and if we put a big coil here and the patient recurs, gets new blood vessels, and they're symptomatic again, we're not going to be able to get to them and treat them. So in this case, we like to use particles to go in here and stop the blood flow. So that's what we did, and this is our post-treatment angiogram, and we can see that, you know, no more blood flow to this area of abnormality, but again, no coils to block us in case we need to go back if they develop new capillary networks going that way.